and both myself and Iqra are final years, and we are teaching this Mod C SBA series. It's 30 questions. Hopefully we'll be done by 8. And yeah, I tend to go through the questions relatively quickly just because I know that your guys' time is precious. So yes, let's just get started. Before I do, can you guys hear me?
Yeah, I can.
Okay, perfect. And can you see me? Hang on, let me just check if I can move the slides. Yeah. Can everyone see the first question?
Yeah.
Perfect. So if you guys just as we go along, put your answers into the chat. And yeah, any questions that you have, you can put into the chat as well. So I won't read the question out loud because I always found that really jarring in tutorials. So I'll give you kind of 30 seconds to a minute to read it, and then you can just start popping in your answers. Okay, we've got a few answers already. Any more? Okay. Yeah, so everyone who put their answer in the chat correctly put doxorubicin. So yeah, these are obviously all chemotherapy drugs. When it comes to the oncology drugs, I would say in general, it's probably on the more low yield side. But it's likely that you'll get at least 1 or 2 questions in the AKT about side effects. So yeah, I just kind of memorized 1 per common chemotherapy drug. For doxorubicin, that's the one that's associated with cardiomyopathy, hence why yeah, this patient had the pansystolic murmur. So I'll move on to the next question. Give a few more seconds. Okay. Yep, brilliant. So everyone got that one right as well. So this is a patient who is obviously presenting with a manic episode on a background of depression. And that obviously suggests that this patient might be experiencing bipolar. And so with in manic episodes in general and with bipolar patients who are having a manic episode, you want to stop any antidepressants because those can actually worsen mania. So you stop their sertraline and you start olanzapine. Obviously, as we know, bipolar is treated with a mood stabilizer, but in that acute manic phase, you want to give them the antipsychotic first, and then the psychiatrist can kind of start giving them the actual kind of maintenance medication, which you'll see a little bit more in the next slide. So yeah, just a little bit on bipolar. Obviously, there's type 1 and type 2. So type 1 is where they have the combination of the depressive episodes and the manic episodes, where a manic episode is defined by having both this like massively elevated mood for more than 7 days alongside psychotic features. So where they start, for example, kind of, I don't know, thinking they're like been commissioned by the Queen to find the cure for cancer or something like that. So very obvious psychotic features are required for a kind of diagnosis of mania. Whereas for type 2, they have still the depressive episodes, but hypomanic episodes alongside that. So they'll still have the elevated mood, but you won't see those psychotic features. And also that will have, there's a lower day threshold, so it will be 4 or more days. So yeah, as I said, in acute mania, you will want to stop the antidepressant. And then it depends on whether they already have an established diagnosis of bipolar, and if they're already on a mood stabilizer, you keep them on that and you increase the dose. But if they are, as with this SBA, if they are kind of, if this is their first presentation of mania, the first line treatment for that is an antipsychotic first. Great, so I'll move on from that to the next question. We'll send out the slides anyway, so you'll get to see, you can read kind of the further information in your own time. Okay, question 3. A few more seconds. Okay, yes. So most of you got 4, which is correct. Someone said 3. So 3 is, I mean, there's still reasonable suggestions of like those medications. But if I move on to the next slide, the reason 4 is the correct answer is because if you think about end of life or palliative care medications, or what we call anticipatory medications, you can kind of group them into 4 groups, and we tend to prescribe all of them first of all in the PRN section, because all of these are medications that can be administered at the end of life, and so they should be on the drug chart so that if a patient would need them, the nurses can give them. So obviously the first group is pain. You can consider the pain ladder, so obviously starting with the really simple ones like paracetamol. However, in palliative care, there is a very low threshold for opioids. So morphine, oxycodone, and fentanyl. Beware that obviously the latter 2 are kind of the first line drugs in renal patients. So with mild to moderate renal impairment, you would start them on oxy, and if they have renal failure, you give them fentanyl. But yeah, outside of kind of the renal patient group, morphine is probably the most common analgesic used in palliative care. Then you have your antiemetics, of which you have a whole list. I would say probably memorize the doses of 1 or 2 or maybe 3. I always use cyclizine personally, because in terms of your OSCEs, and if that is a kind of scenario that could come up where you would have to prescribe that, it's just good to just have like one or two drugs per category where you know the dosage and you can just prescribe it super quickly. With a few of the antiemetics, there are like kind of contraindications and side effects to be aware of. So for cyclizine, that's contraindicated in heart failure. And it's also generally not given to young patients, but obviously in palliative care, that's less of kind of an issue. And then most importantly, obviously, palliative care often happens in the elderly population, of which a proportion will have Parkinson's. And as you know, haloperidol and metoclopramide and domperidone are obviously all dopamine antagonists. So they are contraindicated in Parkinson's because they can worsen symptoms. Domperidone, I believe, is not necessarily contraindicated because it doesn't cross the blood-brain barrier, but definitely haloperidol and metoclopramide. And another contraindication for those antiemetics is bowel obstruction because they're prokinetic, so they could cause perforation if you give those. And then ondansetron is a very common one, also used to chemotherapy patients. So yeah, just kind of be aware of a couple of the, I guess, nuanced facts about the different antiemetics. And then you've got your agitation and restlessness. The one that I always memorized was midazolam. And then obviously also your secretions, which, yeah, you would treat with antimuscarinics like hyoscine butyl bromide, I think is the one that I went with. Sorry, someone just asked, why was the initial dose of morphine so low? Let me just go back. Yeah, so I guess I see your point in that in palliative care, we don't tend to have an upper limit for morphine. And with this patient's background, they are likely in a considerable amount of pain, but we don't know whether this patient has ever had morphine before. They might be morphine naive or opioid naive. So you would start them on a low dose and then titrate up according to their need. So you wouldn't necessarily start giving them a really high dose from the get-go. Does that make sense? Okay, so I'll just move on to the next question then. Okay, so there's a little bit more of a split with this one. The answer is 5. Some people put 1, and I'll go through that in a sec. So I'm sure most of you have figured out that this is a scenario of SVCO, so superior vena cava obstruction, which is obviously an oncological emergency. And the question is, what is the most appropriate initial action? So I guess it's all about the questioning here, because actually 1 is also something that you would probably consider. So it's reasonable to get the radiology, obviously the radiologists involved. But in terms of initial management, we know that for SVCO, you need to give them dexamethasone. And in general, with oncological emergencies, you need to give them dex like stat as soon as possible, just because it reduces kind of the some of the edema, and therefore it basically it stabilizes the patient in that it reduces, well, hopefully reduces some of that acute obstruction on the superior vena cava. So that's the first thing you would do. And then, yes, obviously you would absolutely escalate to the radiologist, to the oncology on-call team. But yeah, in terms of your most appropriate initial management, it would definitely be the dexamethasone. Fine. So next question. Oh, sorry, I think I've accidentally moved my slide. Okay. Never mind, we can talk about it. So there's been a bit of a mix of answers, and I think this is a bit more of a trickier kind of classic UCL style question where actually, in my opinion, most of these answers are reasonable. But I mean, we can go through them. So someone suggested 2, so reviewing his past medical and medication history. I think that's absolutely reasonable and part of one of the things you would do. Yeah, I mean, if that granddaughter is present, asking the granddaughter, obviously you'd always want to involve relatives. Taking as observation again would be part of kind of the GP consultation. However, remember what the question asks. So it's what is the most appropriate way to assess the risk of frailty? And that is, I guess, pointing towards what is something practical that can be done. And if you kind of think about what frailty encompasses, one of the things is instability and falls. And so you would want to do a formal assessment of gait as part of your assessment as to whether you think this is a frail person or not. Obviously, things like past medical history, medication history, collateral history will all be part of your kind of final impression. But in terms of a way to actually formally assess frailty, a gait assessment would be part of that. I just see someone's asked a question in the chat. One moment. One sec. So someone said if he's walking, sorry, one moment. If he's walking slowly, does that mean he is high frailty? Well, we'll move on to that. So yes, in a way, yes. I guess it's not just a slow gait, it's also the stability of the gait, whether they are able to get up from a chair quickly, whether they need to hold on to the rails, the kind of the sides of the chair when they get up, if they're able to turn around, because all of that, obviously, if someone's struggling with that, they're more at risk of tripping, of falling, and that falls kind of a high falls risk obviously plays into higher frailty. So in terms of gait assessments, there are a few here that you can do by the bedside or in GP. So looking at their speed, as I said, looking at how quickly they can get up, at their ability to turn 180 degrees, and then other scoring systems that I would recommend knowing, as in not, you don't have to know the actual scoring system itself, but know of the scoring system, is the Rockwood Clinical Frailty Score and the Prisma 7. So actually, I think in the next slide there is, yeah, so in the top left corner, you can see the Prisma 7, which is a kind of patient questionnaire that they answer. And anything with a score of 3 or above indicates that they might be on the frailer side. I think frailty is one of those things that UCL, or generally Jerry's, UCL loves Jerry's and they love frailty, and it's a bit of a, I guess, waffly subject. So yeah, I think the top right corner summarizes the aspects of kind of frailty and Jerry's quite well. So you want to think about falls and immobility. in these patients. You want to have a kind of get a good idea of their cognitive function, and whether they might be kind of, if they might have dementia or delirium. You want to do a medication review. So thinking about polypharmacy and whether they are on any medications that might interact or put them at more of a falls risk, or more of a postural hypotension risk, for example. You want to think about incontinence as well. And then one that's not here, but one that I know that UCL loves, is also mental health. So if you do have sort of like an OSCE station where, I don't think they'd make you do a frailty assessment, but maybe if you're talking to an older person, in like taking a history, for instance, do throw in a quick mental health question about their mood, because that is a very important aspect of geriatric care as well. Right, next question. Okay, in the interest of time, I'm just going to move on. So you all said the correct answer. You would want to give this patient procyclidine. So this is kind of one of the examples of an extrapyramidal side effect of antipsychotics. So someone suggested in the chat whether this is tardive dyskinesia. So actually it is acute dystonia. So this is obviously an oculogyric crisis. Plus, I assume with the cramping in the neck, they are suggesting they also have torticollis, so where you have this like unpleasant twisting and cramping in the neck. And those are both examples of acute dystonia. And the treatment for acute dystonia and Parkinsonism, which is obviously a different extrapyramidal side effect, is procyclidine, which is an antihistamine. The other two extrapyramidal side effects are akathisia, I think is how it's pronounced, which is where they have this acute restlessness, and you treat that with beta blockers, and then tardive dyskinesia. So that's more, it still affects the face, but it's more kind of automated movements like lip smacking, for example, or excessive blinking. That is an example of tardive dyskinesia. And the treatment for that is stopping the antipsychotic and referring to psych, because they'll deal with it. Yeah, so no one suggests any of the other answers, so I'll just move on. So yeah, I guess schizophrenia is one of the top psych conditions that you really need to know about. It comes up a lot. So yeah, the main symptoms can be remembered with this ABCD acronym, I guess. So the auditory hallucinations, broadcasting is a very common form of thought disorder. They can also have insertion and withdrawal of thought. Delusions of control, so where they have that kind of delusion that they're being controlled by someone, such as the FBI, and then other forms of delusional perceptions. So, for example, they'll see a normal stimulus that anyone else would see, but kind of their brain goes further to interpret that as something. So, for example, I saw a red bus today, therefore I am the king. Yes, so those are kind of some of the main symptoms. And then obviously, so those are the positive symptoms. And then you also have the negative symptoms. So the catatonia, the blunting of affect, the low mood, the anhedonia. Yeah, so you've got kind of those two main groups of symptoms. Management, as we know, is an antipsychotic. Atypical antipsychotics are now first line. And if you've tried 2 or more antipsychotics and they have failed to treat the schizophrenia, you give them clozapine, which is also an atypical antipsychotic, but it's kind of third line because of the fact that it has quite significant side effects and they need to be monitored regularly with bloods. I'd say the most important one to be aware of is obviously agranulocytosis, because that can kind of lead to death if they have an infection. And then, yeah, I've talked through the extrapyramidal side effects, but again, those are exam favorites, so good to know about. Next question. I'm very sorry, I've just revealed the answer again. Hopefully not everyone saw it. Okay. So, yeah, everyone said 2, which is correct. So I think with this one, I mean, all of the answer options are oncological emergencies and obviously complications that are important for us to know. But I think the STEM is suggestive of tumor lysis syndrome because of the fact, well, let's just go through it. So obviously, I think another really important one to think about, especially when they're kind of 3 days post chemotherapy, is neutropenic sepsis. However, if you look at this patient's OBS, he's apyrexial and generally stable. So that rules out neutropenic sepsis. Tumor lysis syndrome is correct in this case because of the fact that they are stable in terms of their OBS, but they are still experiencing nausea, vomiting, diarrhea, which is very suggestive of the fact that they are having some sort of electrolyte imbalance and disturbance, which is caused by the tumor lysis syndrome. Another thing that points towards it in the STEM is the diagnosis of AML, and any blood cancer already puts you at a much higher risk of having tumor lysis syndrome because the chemotherapy is essentially causing all of these cancer cells to burst open and release all of their basically shit into the bloodstream. And that, causes massive electrolyte disturbances and can be quite dangerous. Raised ICP is not suggested here. I guess that they are vomiting, but I think there's not enough in the STEM to suggest it. And then, yes, but spinal cord compression and SVCO aren't necessarily, again, nothing in the STEM really suggests it. So I think the questions got mixed up. There's another question about this patient at some point in this presentation, but we'll just move on to this one first. Okay, so this is a bit more of a split. So the answer is actually 3. But I'll go through the other answers that people have suggested. So what we can tell from the stem is that this is obviously stress incontinence. This lady is leaking urine whenever she coughs and laughs, indicating that there's kind of that increased intra-abdominal pressure causing urine to leak. And as we know, as people have suggested in the chat, the treatment for that is pelvic floor exercises. And then further down the line, if that's not working, duloxetine or even surgery where they can basically put like a band around the sphincter that kind of tightens it again. But this is one of those questions that's a bit annoying because yes, duloxetine would be right. Surgery, I guess, further down the line would also be right. But the first thing that you would do is look for reversible ways, well, reversible causes or lifestyle factors or management that the patient can put in place to reduce the amount of stress incontinence. I think when it comes to GP questions, always kind of structure your answer that way. So it's lifestyle, then conservative management, such as in this case, pelvic floor exercises, and then medication/surgery. So yeah, in this case, you would want to ask about risk factors that can cause stress incontinence, like obesity, because obviously you've got more intra-abdominal pressure, pregnancy, constipation, smoking, those kind of things can trigger kind of the worsening of stress incontinence. And then, as some of you have correctly suggested in the chat, you would move on to pelvic floor exercises. And if that's not working, then duloxetine. But I think we've got a slide on that. Yeah, so I think urinary incontinence is quite a good topic, quite a high yield topic, so good to know about. I think the two main ones to know about are stress and urge incontinence. We've talked about stress incontinence. Urge incontinence is where rather than there being a problem with the sphincter or the weakened pelvic floor muscles, you've got a problem with the bladder itself, so it inappropriately contracts. And again, similarly, you've got the same kind of structure. So you do lifestyle advice first, followed by bladder training exercises. And then you would consider medications like oxybutynin or tolterodone if oxybutynin is contraindicated. Other types of incontinence, examples of that are overflow. So if there's a blockage of the urethra and urine accumulates and then leads to overflow incontinence, you can have a mixed picture, most commonly a mixed picture of stress and urge incontinence. And then you can also have other types like functional incontinence or neurological incontinence, where they've got a learning disability or some sort of neurological impairment, for example, post-stroke, where they can't control their bladder properly. If you do get urinary incontinence in a OSCE history station, remember to always rule out red flags and do the whole safety netting at the end. That's important for GP histories. So you want to rule out any of the kind of red flag features for bladder cancer, for instance, or a colon malignancy. So for example, if they've got associated fecal incontinence or kind of severe constipation or change in bowel habit, it could also be that they've got a tumor in their bowel that's kind of pressing against the bladder. So yeah, always remember to rule out those kind of red flag symptoms as well. Cool, so let's move on to the next question. So this is, sorry that we got the order wrong. So this is back to the patient with the background of AML, post-chemotherapy, has been diagnosed with tumor lysis syndrome. So yeah, this is his next question. Okay, I think I'll move on. Yep, so everyone in the chat said number 3, which is right. So I think when it comes to tumor lysis syndrome bloods, I always remembered it that everything's high apart from the calcium. Importantly, an important marker here is the high phosphate, because obviously you've got a lot of phosphate in your DNA structures in cells. And so when that all spills out, that all goes into the blood. And potassium for the kind of a similar reason, it's stored in cells, so it all spills out. Calcium is low because it also spills out, but it becomes chelated to, I think, proteins and other things. So that tends to be low. But a little bit more about tumor lysis syndrome. So as I said, it's very common in the blood cancers. And it presents as in the stem here. So nausea, vomiting, muscle pain, basically all due to the electrolyte imbalances. It can also cause an AKI, so look out for things like oliguria, abdominal pain. And yeah, in your bloods, as we've just discussed, I think the most important markers that you're looking for are high potassium, high phosphate, and high urea. In terms of treatment, so if you have someone with tumor lysis syndrome, you will want to hydrate them. In terms of, prophylaxis is important because you can give them allopurinol, which reduces that risk of tumor lysis syndrome. And an alternative to allopurinol, if it's contraindicated, is also rasburicase, but I would remember mainly the hydration and allopurinol are important prophylaxis treatments for that. Right, next question. Oh, sorry, one more thing that I forgot to mention is if you're trying to treat their electrolyte, if they acutely present with tumor lysis syndrome, they've got all of these electrolyte abnormalities. Obviously, you want to treat those. So, for example, with a raised potassium, you would go down the hyperkalemia route, etc. But it does happen that these patients have refractory electrolyte abnormalities, and so there's a lower threshold for them to be put on dialysis. Right, someone asked raised urea or uric acid. I think it's uric acid. I'm not entirely sure. I would double check that. I can double check that for you in a moment. I always remembered it as uric acid. I know it says urea here, but yeah. Someone else said uric acid, so thank you. Yeah, due to the DNA turnover, correct. Okay, cool. Next question. Okay. Yep, again, everyone got the correct answer. So I think this is quite a straightforward STEM and presentation. So this is obviously a metastatic spinal cord compression. This patient's got a background of cancer, is coming in with urinary retention. So this suggests obviously cauda equina syndrome. And they've got a background of kind of the red flag back pain symptoms. So I think in terms of things that you would do, apart from maybe the full body PET scan in this instance, you would still do a rectal exam. You want to do basic bloods. You probably potentially want to measure PSA as well. But the most important investigation to confirm the likely diagnosis is the MRI whole spine. You have to image the entire spine to make sure that you're not missing out compression on another level as well. And then does anyone know what the treatment would be for this gentleman? Yeah, DEX. Yeah. So classic oncological emergency treatment, 8 milligrams BD PO of DEX. Cool. Next question. Oh, I'm sorry. There you go. It was in my head. I did think it might come up again. So yeah, we've already answered this one. High dose DEX is the treatment for spinal cord compression. Again, it kind of reduces the edema that happens from the compression or kind of surrounding that area of compression. So that in itself, when the edema kind of dies down a little bit, it reduces some of that pressure on the spinal cord, similar as with SVCO as well. Okay, next question. Okay, a few more seconds. Fine. So again, bit of a split here between naloxone and methadone. So the answer is methadone. And I think, again, the answer here almost lies in the structure of the question. So the question is, what's the most suitable management for this patient's drug dependence? So it's not the most kind of acute management or what's the most appropriate management for their current presentation, which is obviously an overdose, which is suggested by their pinpoint pupils and low GCS. But the question is asking more broadly, what would we give in the long term for a patient like this? So yes, they have presented to A&E and they would be getting naloxone, but long term, NICE recommends either methadone or buprenorphine as kind of management for reducing the patient's dependence on opioids. Any questions about that? If not, I will move on. Yeah, so as I suggested, with as I mentioned, with opioid withdrawal, the acute management is naloxone, but the long-term management is methadone or buprenorphine, and these patients are quite closely monitored in clinics to check their compliance with the methadone. In terms of other kind of substance misuse, benzos are also common, can present similarly. So they're quite anxious, irritated, shaky. They might have tremors if they've had a massive, if they're very kind of dependent, they can also get seizures. That the management for benzo withdrawal is slightly different. So you basically put them on a very controlled reducing dose of that benzo. And then, yeah, alcohol withdrawal, we obviously know there's kind of different points at which different symptoms present. So acutely, they can, again, be anxious, tachycardic, sweaty. And then at around 38 hours, they can have alcohol withdrawal seizures. And then obviously the most important complication to be aware of is delirium tremens, where they can have kind of they can spill over into kind of having delusions and hallucinations and having psychotic features. Acute treatment for alcohol withdrawal is a benzo. So a common one is chlordiazepoxide. Another one that I would be aware of is oxazepam, because chlordiazepoxide is contraindicated in people with kind of severe liver failure or liver damage, which a significant number of alcohol dependent patients do have. So yeah, either chlordiazepoxide or oxazepam. Right, next question. Sorry, someone. Okay, I'll come to your question in a moment, Amar. Do this question first. Okay. Yep. So again, everyone got that answer right. It is retinal detachment. I personally always struggled a little bit with differentiating between retinal detachment and vitreous hemorrhage. So if you are ever, if UCL gives you a really kind of peak question with like one sentence and they give you barely any information, I think with retinal detachment, you do get obviously floaters, but the flashes of light are more common in retinal detachment, whereas with vitreous hemorrhage, you still get floaters, but you also obviously get that red hue in your vision because of the blood in the vitreous space. But yeah, both can lead to acute vision loss. And yeah, I think no one picked the other answers. I think it's quite obviously retinal detachment. Someone asked me to just repeat something on, I assume, alcohol withdrawal. Could you just clarify what you wanted to repeat? Was it about the chlordiazepam epoxide? Fine, yes. So what do you give instead of chlordiazepam epoxide? Oxazepam is another very common one. Yeah, I'm not sure what hospital you're at, but if you remember from like fourth year, at least I saw it a lot at the Royal Free on the kind of hepatic wards, or kind of with hepatic patients. They often had a special drug chart for oxazepam, and like a reducing regime once they were being tapered off it. So yeah, that's another very common one that's used. Right, next question. Two more questions and then there's a little break. Okay. So most people said 4, which is right. Some people also said 3. So again, it kind of the answer is in the question, which is what is the most appropriate next step. So yeah, not all of these answers are wrong. I think referring to a memory clinic is also a reasonable step. But the first thing you want to do is assess their cognition and then take bloods, because you want to make sure that you've ruled out any reversible causes of kind of cognitive decline before you send them to a memory clinic. And that is kind of one of the most important first steps when you have a patient with query kind of dementia or cognitive decline or impairment. You want to check for reversible causes. Common reversible causes are things like pseudo dementia, so when they have depression, that can often in the elderly manifest as having kind of cognitive, a bit of a cognitive impairment. Others include hypothyroidism, normal pressure hydrocephalus, hypoglycemia, for instance. So there's lots of different kind of things that could cause their cognitive impairment, which you would want to rule out first. The next slide, I won't talk through it because of time, but it's just a good table summarizing basically the common types of dementia, which is very high yield and I'd recommend knowing. Yeah, so obviously you can look through those in your own time. So yeah, as I said, when you have a patient in front of you where you think, do they have dementia? The first step is to assess their cognition. There's obviously lots of different types of screening tools for that, and then to take bloods and examine them. And then if you have ruled out reversible causes, that's when you would refer to a memory clinic, which is where they'll have more kind of substantial tests. Right. Last question before a break. Okay, a few more seconds. Yep. Okay. So most of you said CBT, which was right. A few people also suggested citalopram, and I'll go into that in a moment. But yes, so in terms of the STEM, obviously the diagnosis is obvious. This is this patient has got depression, but in terms of what our first line management is, depends on the severity of their depression. And this STEM is quite clear about the fact that well, I guess it suggests that he can still get on with his life, carry out daily activities, things that he enjoys, in this case, baking. So it kind of points towards it points towards the mildest end of the spectrum of depression. They've also ruled out red flag symptoms such as suicidal thoughts or highly elevated mood. So yeah, this is definitely just a mild form of depression. And the first thing you would do is a form of therapy such as CBT, basically. If they had more severe depression, you would start them on both. I think there's actually a diagram on the next slide. I'll go back to this in a second. Yeah, so this is a nice diagram. So if they have mild depression and like minimal functional impairment, you start them with the psychological intervention. So either kind of self-guided, self-help CBT or like group-based CBT. And then if you are thinking that they're more on the moderate or severe end, that's when you do individual CBT, which is kind of more high intensity, and you would start them on an antidepressant. Just going back one slide. So yes, depression is another really high yield topic. So just know all of the symptoms that you would be asking about. So you've got the major symptoms, so the low mood and anhedonia, and then a bunch of minor symptoms, of which they can have one or more. So weight loss, sleep disturbance, concentration difficulties, appetite changes, and obviously also suicidal thoughts. So yeah, there's in terms of severity, yeah, you want to look at how many of these symptoms they've got and whether their normal activities are impaired as well. Right, any questions about that? I thought they need at least 2 of the core symptoms. Let me just check what they have here. So he has got low mood. He denies lethargy. I guess, yeah, you make a good point, actually. I generally think anhedonia, yeah, I mean, I think you're right in that low mood and anhedonia are the 2 major symptoms that obviously are required for a depression diagnosis. So yeah, I think you make a good point. I'm not entirely sure. But then again, I think if this patient came into GP, you would obviously still think that there's some sort of depression going on. You wouldn't just be like, oh no, just because he doesn't have any features of like lethargy or anhedonia, this isn't depression. So you'd still kind of probably go through the same process of suggesting self-help and like the websites where they can do mindfulness and all of that stuff. So yeah, I think it's not as kind of textbook as that. But I think you make a good point, and that generally we look at the 2 core features, which are the low mood and anhedonia, and those are obviously what you need for a depression diagnosis. But yeah, maybe it's a bit more nuanced than that, and you make a good point. Right. Oh, okay. So here's a slide on pseudodementia. I did obviously talk about that in the context of reversible causes of cognitive impairment. So yeah, it often happens in elderly patients where they've had some sort of precipitating event. So, for example, the death of a loved one, and then that can often spiral quite quickly into this kind of dementia type picture. But yeah, you would then kind of figure out through the history that this might actually not be a true dementia. Right, so we'll do a little break and then Iqra will take over the second half of the questions. But in the meantime, if you could just scan the code and fill in some feedback, that would be really helpful. Thank you.
Thank you, Finola. I'm just going to launch a quick poll about, because I know the last 2 times we've done this, everyone's kind of just wanting to carry on. So if that's yeah, okay. Yeah, I'm getting the message. I don't think you guys can see that. But okay, so I think we have generally everyone wants to just carry on. So okay, Finola, do you mind if I take over the share screen? Oh wait, I can just kind of, yeah. Okay. Everyone can see that, okay? Well, I'm gonna assume yes. And can everyone hear me?
Yeah, I can see and hear.
Okay, cool, cool. All right, so next question, and I am going to talk through it because otherwise I will not give you enough time to do the question. I get bored. So, are we still recording? Yes.
Yeah.
An 83-year-old female who has been admitted onto the ward for treatment of her delirium second to a UTI has been found sitting on the floor after having fallen over while trying to get into her bedside chair. She reports feeling dizzy as she was getting up, was awake throughout the fall, and did not hit her head. What is the best initial investigation to carry out? Okay, good. So most of you have are going with the right answer, which is two. So we would start off. So this just sounds like a normal syncopal episode. Like they're dizzy when she stands up and then she's fallen, but there's no real red flag symptoms that would make us think that we need to investigate more. If this was a new delirium where we didn't think it was secondary to the UTI, we could start looking for, a chest X-ray. Urinalysis isn't that useful. We know she has a UTI. But yeah, so I think chest X-ray we would do if we thought this is a new infection or something that could be causing a new delirium, but we already know what's causing the delirium. ECG, we would do that if we thought that this was cardiac, but that tends to be more like sudden, and it wouldn't be with getting up necessarily that they would get that. And yeah, and then CT head, we don't need to do that because they haven't hit their head, hit their head. Okay. So a little bit about falls. So falls is a really high yield subject. It came up in our finals. So it'll probably come up either in your finals this year or next year. So you need to obviously get a good history, find out what happened before, during, and after the fall. You want to examine them to see if they've got any injuries. Do their basic obs, make sure, like you can check their lying standing blood pressure, you can check they're not febrile, things like that. Think about medications. So, lots of medications are a risk factor for falls. And so consider like, is there a way that we can deprescribe? Because especially with something as simple as postural hypertension, like all you need to do is get rid of the meds normally. That'll fix it because most older people do have hypertension. So if you get rid of the things that are causing them to have low blood pressure, they'll probably be able to maintain it on their own. And then investigations, as I said, like it depends what you think could have caused it. You also want to think about their risks. So think about, are they at risk of a fracture from these types of falls? Because those are like our fragility fractures. And I think they call it silver trauma, which is breaking a bone, but just from like a standing height. Obviously, if I fell from a standing height, I wouldn't break anything, but someone with osteoporosis will. And so you want to think about sort of their risk of fragility fracture, because that is a really high, if someone breaks their hip, I think they have like a 50, or I think 1/3 of patients who break their hip die in the next year. So it has a really high mortality rate. So we can kind of prevent that by kind of considering sort of forward thinking and doing like this multifactorial risk assessment to just make sure they're not falling consistently. Managing it, yeah, try to figure out if there's a cause and treat that. And then there are also other things that even if it is postural hypertension that was the cause. There are other things that we can do just in general to improve someone's risk of falling. So, for example, strength and balance training, have a look. So we can send occupational health to the home to have a look at it and see if there's anything that could cause them to fall, you know, like things like loose carpeting and stuff. Make sure that their vision's okay, and that they've not got any like vestibular issues. And as we said, like down regulating their meds, basically. All right. Next question. So a 21-year-old male presents with a painless testicular lump he noticed 3 weeks ago. He also notices shortness of breath for 2 weeks. His GP orders a chest x-ray, which is shown below, or to the side. Malignancy is suspected and he is urgently referred to the local oncology service. What tumor markers should be ordered? Okay, fab. We're getting lots of answers in. So the majority of you guys have gone for one, which is the answer we've got here, AFP and beta HCG. I don't know, something happened with the numbers here, but some of you did go for 5, and I can understand the reasoning behind that. So always read be careful about the wording of the question. So if this question had said like, what tumor markers should be ordered in order to diagnose? Well, tumor markers don't diagnose. As you can see here, there's lots of overlap. So like CEA is all over the place and things like that. And also, not only is there lots of overlap, but there's also like you can have a cancer that just isn't really presenting any of these tumor markers, and they can still have a cancer. So being negative for tumor markers also doesn't rule it out. So if the question was something about like making a diagnosis, then yeah, you probably would say none of these would make a diagnosis, because that's true. However, because they are being sent to the oncology service, and oncology would like these things to be sent before they get there. So, you know, there are like basics that an oncology would expect, and they would expect you for you to send the relevant tumor markers just in case that they're high, because that helps back up the evidence. And so in this case, for testicular cancer, that's AFP, your alpha fetoprotein, and beta HCG. And then I've just put this up here so that you can sort of revise some of the other tumor markers. But as it's shown there is a lot of overlap. It is quite difficult, but you know, in SBA land, it's a bit easier. They don't try to trick you too much. Question 18. So a 55-year-old woman presents to the emergency department with pain in her right eye that's been going on for 4 hours. She's also feeling sick. On examination, the eye is red, the cornea is cloudy with a dilated right pupil. Which of the following is the most likely diagnosis? Yeah, great. You guys are all getting it. So yeah, it is, as you've all said, acute angle closure glaucoma. So this, as it says here, we do need to send them straight to like ophthalmology, like emergency A&E. So in terms of how we know that it's glaucoma, it's really from the description. So they always like to say cornea is cloudy, and you expect for them to say that it's like in this fixed dilated position. And I've just put up these photos just to help you guys compare how each of them are meant to look. So glaucoma is here in the middle. This is your subconjunctival hemorrhage, which is just really not a problem, but might freak people out. Episcleritis and scleritis can be quite difficult to delineate. That's when you have to do the whole, oh, if you like, are you able to move the vessels and things? I don't really know how in real life they would do that. Like you kind of just use cotton bud and you try and touch their cornea, but like surely they would hate that. So I don't know in real life if they would actually check that, but that's what is sort of in the textbooks. And then your anterior uveitis, you expect it to kind of be all red. Why is the cornea cloudy? Good question. I think it's because if you think about like what glaucoma is, it's that you're not being able to drain the fluid, the aqueous humor. And so I imagine it because it's not draining anymore, because it's blocked, because the angle's too small, that it would sort of build up. Exactly. So someone said corneal edema, which is a much more concise way of saying what I'm trying to say. So I think it's that buildup of aqueous humor, and the fact that it's not draining as it should that is creating this cord cloudiness. I could be wrong, but I think that's my understanding of it. Okay. Any other questions before we move on? And like the other thing about glaucoma, which wasn't in this question, was that quite often the SBAs will say something about like they were sat in a dark room, like they were sat in a cinema or something like that. Because obviously when you're sat in the dark, your pupils dilate, and so that's closing the angle even more. And so that can be like the trigger for glaucoma. All right, question 19. A 16-year-old female has come into A&E 12 hours after having taken 22 paracetamol tablets. These were taken soon after she received news that her grandfather had passed away. She currently looks well and says she has no past medical history, takes no regular or recreational drugs. The triage nurse has kindly weighed the patient for you. She's 60 kilograms. What is the single most appropriate next step? I'll give you guys a little bit longer because this one's quite tricky. One or two more answers. So this one is quite difficult. So the things that we want to pick out is that what is the time frame? So if it's within the first hour, you can immediately give them charcoal anyway, activated charcoal. But because it's past the first hour, you can take this out. Now, she probably will get a referral to liaison psychiatry, but that's not the first thing we're going to be doing. We don't encourage the patient to vomit in general, like that's just not a thing we do. But also, that would be pointless if she took paracetamol 12 hours ago because it shouldn't be in the stomach still. And so it's between 4 and 5, which you guys have all narrowed it down to. Most of you guys have gotten the right answer, but it is really tricky. So this one is we start NAC. So basically it's based on the time frame, but I think there are some other things to think about too. So so if they present within 8 hours, that's when you take the paracetamol level and you try and take it at the 4-hour mark. But this is quite a late presentation. And so what you need to decide is this a large amount of paracetamol? So we all know that one paracetamol tablet is 500 milligrams. And basically you need to know this equation that it's like 150 milligrams per kilogram is sort of your cutoff point between starting NAC versus attempting to plot it on a graph. And then beyond 24 hours, you kind of would expect LFTs, you'd expect the liver to be unhappy if it was going to be unhappy. So you'd expect them to be jaundiced or to have hepatic tenderness. But the other thing to think about, which isn't on this slide, is also like, is this a high risk patient? So these are like the really tough questions. Is if this had come up and your patient was under 50 kilograms, or they were an alcoholic or something like that, why would that be a higher risk? Does anyone know why those patients are higher risk? So this is all to do with like the way that the liver processes paracetamol. So the liver is able to break down paracetamol into non-harmful byproducts using like glutathione, but certain people have depleted stores of glutathione, and that's people like people who have chronic alcoholism, people with a really low body weight, people who are anorexic. So that's another thing to consider is like, are they deplete of glutathione? Because that essentially means that their liver is not going to have as much capacity to get rid of paracetamol as the average person would. And so if this patient had been under 50 kilos, it would have been start NAC, like regardless of the paracetamol level. So that's something to bear in mind. Like look for these risky patients in your questions and in real life. And then just a little bit about how people present. So paracetamol overdose, it might just be sort of your nausea, your vomiting. If it's more late presentation, it could be jaundice, hypoglycemia, just like really like unwell, low GCS. And then you're going to maybe do a serum paracetamol level, but it depends, as we've said. And then you could also just do like your overall like LFTs, Usanese, clotting, take a blood gas. And then with aspirin, the thing to pick out, so I don't feel like I saw a lot of SBAs on aspirin over the years, but one that I did see a lot was this whole respiratory alkalosis. So remember that aspirin is like salicylic acid. So it is an acid, and when it's broken down, it does create a metabolic acidosis. But this is like a really popular thing for them to examine is basically like your body will, we know about compensation. You'll compensate by hyperventilating. So initially there's a respiratory alkalosis, and then as it like progresses, it becomes metabolic acidosis. And so this is like a fine point that they do like to examine a lot on SBAs, I feel like. And that's why getting a blood gas is really important, because it does help you distinguish. Like sometimes it's sort of like a figure out what they've taken question. And so what's coming out on your blood gas might help you with that. And then opioids, it's sort of like low GCS, like respiratory depression, and you're giving naloxone. So moving on, a 61-year-old woman presents to her GP with a 7-day history of abdo pain, bloating, and constipation. She's normally fit and well. On examination, abdomen is distended and diffusely tender. Which of the following tumor markers, if raised, would most likely explain her symptoms? Great. So I'm getting a lot of right answers. I'm glad that you guys are recognizing this. So what tumor do we think this patient unfortunately has? Yeah, I'm getting some direct messages, ovarian. Yeah. So this is your kind of classic presentation of ovarian cancer. It's really difficult because ovarian cancer quite often presents very late because it has like these very non-specific symptoms. So the main thing is, remember that like people don't present with IBS when they're 50 or 60 years old. So if someone is getting like a change in bowel habit, and especially if it sounds very IBS-y, then that is like a red flag. Um, quite often they don't necessarily present with abdominal pain, and it's a lot less threatening looking, the presentation of symptoms. And that's just because ovarian cancer, it tends to present very late. And yeah, our tumor marker is CA125. But yeah, so this is something to look out for in like GPs have to be like have a high suspicion and just send off a CA125 if you're worried. Um, and yeah, so question 21. A 53-year-old woman presents to her GP with a 2-month history of rectal bleeding. It is not painful. On examination, there is no sign of hemorrhoid or anal fissure. What is the most appropriate action for the GP to take? Okay, this one's a really tricky one, and we've got, as you guys can see, some split answers. So I'll give it a bit longer. So the very first thing you want to do is you do want to do a digital rectal exam. but they've already done one here. So on examination, you can't see hemorrhoids or anal fissure. So great. That means you can rule that one out because you know that they've already done that. And then then you're trying to decide. You probably shouldn't send the patient home with lifestyle advice because what are we worried about here? What is rectal bleeding a potential sign of? Yeah. So colorectal cancer. And so we're always on the lookout for it. And um, so there has been a recent change in guidelines, which is why your answers are quite split and why I wanted to cover this today. So this changed last year, it changed August 2023. That it used to be that you'd put them on a 2 week wait to colorectal and then they'd have a colonoscopy essentially. But now everybody gets a fit test. Don't ask, I personally I have opinions about this because I don't really believe we should be screening people if they have a symptom. Like I don't see the point in this. But that's what we're doing now. So this is new. As a result, it might not be part of your exam because I know UCL say they don't examine things that have just recently changed. However, it did technically change last year. So I just thought it's worth telling you guys because it could still come up if they were feeling really mean. And it is obviously relevant. You guys need to know what's the most up-to-date information. So yeah, so the first thing we do now is fit testing. So our patient's over 50 and has unexplained rectal bleeding. We still offer them a fit test and then we refer them on the 2 week wait cancer pathway if their fit test is above 10. Um, as I said, I don't make the rules. I wouldn't recommend this myself, but I'm also not an expert, I suppose. But I think it's a bit weird. But this is what NICE says. Um, so well done to those of you who know, but also no worries if you didn't know that because it is a very new, and I think lots of people are like quite confused because guidelines change and like QuesMed, for example, older questions will now be out of date, and I don't know if they've necessarily removed those, which is why I would just wanted to make sure you guys had the most up-to-date information. So question 22, a 69-year-old man with metastatic prostate cancer presents with worsening pain. He's currently taking oral MR morphine, 16 milligrams BD, is decided to convert this to subcutaneous because he's frequently vomiting. What is the correct dose of morphine to be given over a 24-hour period using a syringe driver? Yep, you guys are getting this. It's easy maths. Yes, great. So this is kind of just you either know how to convert to subcut or you don't. And if there's any there is a lot of opioid dose conversions and you can't remember all of them. That would be silly. However, you should probably know this one. This one's like the easiest one. This one's the one that I remember. So oral to subcut, you half it. That's basically it. But always watch out for a trick. So this one's saying 24 hours and across 24 hours, because it's twice a day, it's 120 milligrams. So it's 120 divided by 2. So it's 60 milligrams, which you guys all got correct. So not a problem. This will come up. It will be very relevant for you to practice this for your prescribing safety exams in January next year and stuff like that. So this is what I've got from so prescribing in palliative care page on BNF is really, really useful. It has the drugs and the doses that are used in palliative care of everything. Because I know, you guys were talking earlier about some palliative care medications like your anti emetics and things like that. It has all of them in one page, which is really useful. And it also has this very helpful dose conversion table that I think is very, as I said, helpful. So check that out and also use it in your PSA. But yeah, so that's there. Question 23. A 40-year-old man presents to the emergency department with a 2-day history of double vision and pain in the left eye. On examination, his left pupil lies in an inferotemporal position. There is an ipsilateral ptosis, and the pupil is dilated and fixed. Which of the following is the best investigation to consider? I'll give it just a little bit longer because we're not getting quite as many answers in. I know this is a tricky one. So which cranial nerve is affected here, do we think? Or, I mean, I'm, yeah, perfect. So cranial nerve 3. And essentially what this question is asking you is this a surgical third nerve palsy or a medical third nerve palsy? And so even if you don't know from this bit which one it is, looking at the options, you can kind of narrow it down in that way. So always have a backup plan. If you don't know what the answer is, always have a backup plan of how you're going to figure out what the answer is. So look for the pattern sometimes if you're really stuck. And so, you've got your diabetes, you've got like a vasculitis type thing or rheumatological issue. MRI is something probably more physical in the brain, like maybe, I don't know. And then CSF, maybe, I don't know, an infection, who knows? What are they getting at there? And then fundoscopy, just looking at the back of the eye, which probably wouldn't be that helpful. And so essentially, we're going for a surgical third nerve palsy here. So so essentially the only way that you can tell between a medical and a third nerve palsy is what's going on with the pupil. The pupil should be unaffected if it's a medical third nerve palsy because it's kind of happening around here. Whereas if something physical is compressing your third nerve, you've got your parasympathetic fibers that wrap around your cranial nerve. And so those get affected as well as the cranial nerve. And so that's why your pupil becomes dilated. So think of it as anything that could be pressing on, so coming like physically coming from the outside is your surgical third nerve palsy. Most commonly it's your POCA, your posterior communicating artery aneurysm. Whereas these things are more like medical reasons, and then fundoscopy is just useless. So good job those of you who didn't get it, but this one's really, really hard, and it's just about knowing this. But as I said, if in doubt, figure out another way of getting to the answer, because sometimes you do just have to sensible guess. Question 24. A 68-year-old man presents to the A&E with a painful red eye and reduced vision in his right eye. He had a cataract surgery 3 days ago. On examination, there is hypopyon in the anterior chamber. What is the most? Yeah, I'm glad you guys are like immediately in with it. Yeah, so essentially, as soon as you see surgery like 2 or 3 days ago, it's probably going to be endophthalmitis, because that's literally like a complication of intraocular surgery. And it looks like, well, it looks like this. To be honest, this isn't really like this is just any hypopyon that I just wanted to show you guys what it looked like. But yeah, so easy marks, just cataract surgery and ophthalmitis. Obviously, in real life, it's not like that. So in real life, I got really excited because someone came in. Well, not excited, but someone came in like a day after surgery, and I was like, "It's got to be endophthalmitis," and it was not. So this is only for an SBA, but it is a good, easy mark. All right, question 25. A 67-year-old female patient has presented to A&E with increased urinary frequency, dysuria, not feeling well, as confirmed by the cholesterol taken by a partner. It is currently extremely difficult to get history from her as she appears confused, very agitated. She's become aggressive towards all the staff in A&E. She has past medical history of type 2 diabetes and Lewy body dementia. What is the most appropriate initial step in management? Okay, this one's super, super split. I think everyone has gone for each of the answers so far. Okay, very, very split. So there's kind of two things that they're testing here. So first of all, there's what do we do in a situation with an aggressive patient? And the answer is always to de-escalate. That's normally, so if you ever see on your options de-escalate, put that one first. Now, this one's a bit of an unusual question because they've tried to like test that, the idea that we don't medicate first off. We really put off medicating if we can, because obviously sedating people is like not okay, not like, you know, it's not ideal. So they've tried to like make it a bit trickier by saying examine the patient. Because you know, but essentially it's whatever's a conservative management. Normally the option isn't things like that. It's normally like the one that I've seen a lot is de-escalation tactics. And if there's an option for that, you should always start with de-escalation. Now, the other bit that it's teaching. So I've got a question, but she's being aggressive. Yes, but you still don't medicate people if you can avoid it. So there are also other things that we can do, even at beyond de-escalation, without needing to necessarily medicate them. So sometimes there's a decision of like, if, for example, someone's being aggressive and they don't want, I don't know, like their metformin. I've seen this before, like a, you know, a patient with dementia is really aggressive and is refusing her metformin. We can just not give her the metformin. Like there's a decision about like what's life threatening and what can we leave her alone about. So there's that. There's like other alternatives. In this case, probably not because she's just coming to A&E. We do need to examine her. But also remember, like you know, you're in a whole team. You're not. We're not telling you to like put yourself in harm's way. And that's why I don't love this answer so much. I would have written it slightly differently and just put the de-escalation. It's normally de-escalation because you do get taught that. And remember also, you know who gets taught it way more than we do? Like the other healthcare professionals. So like, for example, on psych, like the nurses on psych could take someone down like that. Like you are in very safe hands. And even though nurses outside of psych aren't quite so like first aid trained, they are still trained better than we are in de-escalation. So what you want to do is get your team involved and try your best to de-escalate the situation because it, you know, if you're sedating someone, that's kind of like a doll's situation. Like, you know, it starts off this whole process about like, are you doing best practice? Are you putting the patient first? Things like that. So it's a delicate balance. It depends, you know, it's not said physically aggressive. If she's just like being super racist, unfortunately, you kind of, you know, that's a type of aggression, but you'd probably still treat her without sedating her. Whereas obviously if she like sucker punches someone, then you probably would start escalating. So there's shades of gray and it's not ideal. Obviously, priority is keeping yourself safe. But here it doesn't really say that she's like being physically aggressive. She's just saying she's being aggressive. And we always try to just calm people down first because normally, remember, she's got delirium. She's got delirium. She can probably be calmed down. It just, you know, it requires that training, which some people do have. You only give calming meds if you've tried something else first. Now, I do think, yeah, I personally don't love examining the patient. I think I would obviously you'd want to calm her down first. So this is an ideal question. The other half of this question is that if this wasn't an option, and if they'd said, so normally when they want you to go for the medication, they'll give you a sign in the question, which is de-escalation techniques have been tried and have failed. So they'll normally say that in the question if they think that you should move on to the next step, which is medication. And then it's about knowing that you can't give her haloperidol. We were talking about this earlier, like Finola mentioned this. We wouldn't be giving this in someone with Parkinsonian type symptoms, and Lewy body dementia kind of falls into that. Like it's like a dopaminergic issue. And so you wouldn't want to give them something that would heighten that. So and also I think benzodiazepines tend to be like the first line anyway, regardless. But we wouldn't, as I said, jump to it. But it is really difficult, and I can see that some of you are quite upset by that in the comments. Just don't blame me. It's not I'm just telling you how to pass these SBAs. And also, to be honest, in real life, like as I said, I've seen this happen. Patients are aggressive, and one of them was like, "I'm gonna break your wrist." The consultant didn't sedate her. He just talked to her and carried on talking to her. And eventually they gave her life-saving insulin. So I know you don't believe me, but it does genuinely work. You just have to, you have to give it a chance, because we really don't want to sedate people if we don't have to, because you could be sued if you know, like, think about it. If you've done something that, if you've maybe jumped the gun a bit, you could get yourself into trouble. Okay, a bit about delirium as a whole. So it's an acute syndrome. So, bear in mind, like, delirium versus dementia. If this has been going on for 6 months, it's not delirium. And it's an impairment in consciousness. It fluctuates. So it's called like sundowning, that it gets worse at night normally. So like, it's funny because the day team will be all like, oh, she's lovely, that old lady. And then the handover team are like, no, she's not. No, she's not. And it's because you're literally getting a different person between night and day. Abnormal perceptions, so they might see hallucinations, they might have delusions, they can be really scared and agitated and aggressive. And there are two types. So this is something that isn't recognized enough, is everyone thinks of the hyperactive behavior, but there is also hypoactive. So if they're just like, it's kind of like a super bad, it's kind of like quite severe depression, where it's just like they're quite apathetic, they're very slow and withdrawn, and it's just out of character for them, and it's happened in a short time. Then that's hypoactive delirium. And then the common cause, I always use this acronym, pinch me. So pain, infection, nutrition. So if they're just malnutrition, constipation, hydration, medication, and environment. So people will sometimes get like acutely delirious just because you've changed them from one ward to another, which is why we really shouldn't do that, but we do. And as you can imagine, if you're like a bit unwell, it is really disorientating, and it can just push you into delirium if you're disorientated. And that's why there are like conservative measures for, like, for example, like sometimes we'll get like a family member to come and help with the de-escalation, because the patient will recognize them. They might not recognize everyone else, but they'll recognize them. And so it helps ground them a bit, things like that. And then in terms of management, we basically want to go through your pinch me and basically think about what could be causing this, and do your history, do your exam, do your obs. I don't know. I don't really see many people doing an AMTS, actually. I see more people doing the 4AT. That's more appropriate for delirium. I don't think AMTS is as used. And then essentially find out what's happening and try to reverse it. And as I said, like, there are, ways that we can do that in a conservative way. It's funny because that's why you have the date and the time. Sometimes you see it written on like a little whiteboard in the ward, but it's not funny, it's kind of tragic, but quite often those are out of date. So it's telling you like 2 days ago. And I'm like, well, no wonder patients are confused. Like, the way that we test with the 4AT is we ask them, like, where are you? What year is it? What day is it? But to be honest, we don't really do enough to tell them that, because the boards are wrong. So if you can do anything as a medical student, go around and make sure that those are correct, because we're just gaslighting our patients. Anyway, and then sedation is the very last resort. So, question 26. A 22-year-old female has come into the GP surgery with recurrent thoughts that her hands are dirty, and so she tends to wash them regularly. She says it's affecting her life a lot, and if she does not wash her hands, she feels quite anxious. This has been going on for the last 5 months. She has no other past medical history. What is the single most appropriate management for this patient? I think you guys have all picked this up from question 15. So, similar to question 15, a lot of us think of medication as the first line, but obviously the very first thing that we want to do, especially if it's not too severe, is try like the therapy. So the first thing we're going to do is CBT. So this is the same as the depression thing. So I would say, like, in regards to that, in reality, I think, most people will get offered both of these. I've never seen someone just get offered CBT in reality. In GP land, they pretty much will say, you should have therapy. That is the best thing. But we can also start you on this medication, because obviously the NHS has all these pressures. So there's like this long wait list and things like that. So unfortunately, because of the reality of the situation we're in, you might end up seeing, and this is why I think people got confused by question 15, but they didn't get tricked this time, is that a lot of people would put the medication because that's what they've seen in real life, that people will get put on medication first. But the ideal practice is that we should be offering them like non-medication first, basically. Yeah. Okay, so a bit about the anxiety disorders. So we've got obviously our phobias, which I think everyone knows about because I personally knew about agoraphobia since I was 5. Like we love phobias. So generalized anxiety disorder, normally the long-lasting periods are meant to be like 6 months is like the cutoff. Panic disorder, which is like basically having panic attacks, but it's not associated with a trigger. Like obviously people do have panic attacks if if you're about to go into a really big exam or something, but this is where it's happening with no trigger. Acute stress reaction. So these are fine details that they like to test you on SBAs, SBAs, which is like acute is within 1 month, whereas post-traumatic stress disorder is beyond 1 month. And adjustment disorder. So things like, for example, like grief. Obviously, there is a normal amount that people grieve, apparently. Whereas if it's lasting like, I think 2 years, then you'd say it's an adjustment disorder because they've not moved past. Obviously, that's a bit debatable because some people would say, well, grief is going to affect everyone differently. So I have seen that debate happen, but officially, that's an adjustment disorder. And then OCD, which is characterized by obsessions and compulsions. So obsessing about things that are worrying them, and then compulsions, which is like the feeling of the need to do things. And it helps to alleviate your like anxiety about your obsessions. More, so this is more about the what's the word, how we manage it. And as you see, like number one is always like self-help, 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 self-help. And then your drugs is like your SSRIs for basically all of these, any anxiety thing, you're going to start with SSRIs. You don't really need to know beyond that. I wouldn't go into too much detail. I would just know your first line. And know that OCD is at a higher, you start them at a higher dose than you would with like a generalized anxiety disorder. So it's like 80 milligrams instead of lower. Okay, question 27. So an 18-year-old male with a history of anorexia has been referred to hospital by his GP. He has a BMI of 13 and has lost a significant amount of weight in the last month. He's been started on NG feeding, but the nurses notice he has become confused. Given the likely diagnosis, what would you expect to see on his bloods? Okay, well, you guys have done really well. I always found like these bloods to be some of the hardest things for me to get my head around because obviously there's like tumor lysis and there's refeeding and which ones are which. So, good job, guys. So it is indeed one. So with refeeding, I really only got to grips with the blood when I really understood why it's happening. But essentially, obviously, they've not been eating for a long time. Then you start giving them feed and the insulin like shoots up. And insulin, remember, it moves things back into cells. And so your potassium, your magnesium, and your phosphate will be shoved into cells, but that will mean that in your serum, you don't have enough of those things. And so it can be very dangerous. It can cause like seizures and it can even put someone in a coma. So to be honest, you should kind of like, if you know that someone has not eaten for I think over a week, they're at risk of refeeding, and so it's something that you should be like preemptively monitoring as an F1, and like you'll probably be told by your consultants to do that. Like people are very aware of refeeding syndrome, and yeah, it's low magnesium, low potassium, and low phosphate. So a little bit about eating disorders. So anorexia is sort of your triad of restriction, fear of becoming fat, and also like body dysmorphia, so they don't really see how they really are. It has all of these complications that are quite useful to know about. So like, proximal myopathy, so you can do the whole like stand up with your arms crossed over and test that. They're at a high risk of osteoporosis, cold intolerance. They get these lanugo hair, which are like these baby hairs, which is something you can find on examination, and they're at risk of arrhythmias. So are is not here, but so are people who suffer from bulimia. So these patients will have like regular ECGs. Bulimia is like a strong food craving followed by binge eating, and again, it's sort of in thoughts about like dreading about being fat, and it can have more physical like things that you see. So you can see like your Russell sign, you can see which is like calluses on the finger because you've been scraping like the back of your throat, and like salivary gland enlargement and erosion of teeth, and even esophageal ruptures. Like you could end up with like an upper GI bleed. How many more questions? I think this is 28, so we've only got 2 more. And then binge eating disorder is basically bulimia but without the purging. Oh, I can't. Yeah, okay, we've got 3 more inclusive. We should be finished by 8, I think. A 50-year-old female presents to A&E with a 10-hour history of fever, which she reported at home as 39 degrees. She has a background of AML, for which she has been receiving chemo. Her last cycle completed 3 days ago. Blood pressure is low, heart rate's high, she's febrile, blood cultures are sent, she is found to have a neutropenia. So what antibiotics? And I think everyone's really on it, so I can move on. So it's Piptaz. Now, I feel like it's a bit unusual to have the neutropenia. Normally, they just present with they're on chemo, they've had recent chemo, and they're unwell. And even from that, you can tell it's neutropenic sepsis and you can start them on Piptaz. You don't have to wait to have confirmed neutropenia. Because also, I've seen people who have been treated for neutropenic sepsis where it's not been neutropenia truly, because like they've been like 0.6 and the official cutoff is 0.5, but like all of it's kind of relative, and so the doctors aren't going to be all like, oh well, you're fine now because you're 0.6 instead of 0.5. So to be honest, in real life, if you think that they're at risk of neutropenic sepsis, you just start them on antibiotics straight away, and then you go get your cultures, go get your gas. I suppose a gas wouldn't take that long, so yeah, but it's Piptaz. 29. So a 78-year-old lady presents to GP complaining of her eyesight. Over the past 2 years, she's found it difficult to read newspapers. She's otherwise fit and well. On examination, her visual acuity is 2 out of 6 in both eyes. Fundoscopy shows bright yellow deposits on the macula. Which of the following is the most likely diagnosis? Yeah, brilliant. And for extra bonus points, what are the bright yellow deposits called? Yep, fab. You guys are really good at opthal. So yeah, this is your dry age-related macular degeneration. And really the way that I would differentiate between wet and dry is just how fast the onset is. So this has happened over 2 years, whereas your wet age related macular degeneration, that's really long, you expect it to happen more in like a case of like weeks. Also, you can also differentiate from the way that they're losing their eyesight. So in wet, it's like central, and then it's working outwards, whereas dry, you start losing your peripheral vision. So quite often in the question, it will say things like they've started tripping over things a lot, and it's because they've lost that peripheral vision. What was the other thing I was going to say? Oh, and also keep in mind that dry macular degeneration can become wet age related macular degeneration, so it can go from one to the other. So just because it says like they have a history of this, it could still be this, if you get me. All right, last question. And this one's a stinker. All right, an 89-year-old male attends Falls Clinic after having 4 falls in the last year. He has a background of Parkinson's disease, hypertension, osteoarthritis, hypothyroidism, hypercholesteremia, urinary incontinence, and AF. His obs in clinic are he's afebrile, he's saturating okay, rest rate is 17, heart rate is 65, blood pressure is 110/70. The consultant wants to cut down on his polypharmacy. He's taking all of the medications below. Which of the following is the most suitable combination of medications to stop? I'll give it a bit longer because obviously this one's really tricky. Okay, we have one no clue, which I appreciate the honesty. Okay, one more. Okay, so you guys are split between 2 and 5, which is really good because it means you've narrowed it down to the top two, really. So what you want to think about with this is um what will immediately kill them or cause them like a lot of morbidity and side effects if you immediately stop it versus what is there for secondary prevention, which is not really worth doing secondary prevention because that's obviously like thinking about a long term, like it's forward thinking, whereas we're thinking about how they right now, we want to make them as healthy as possible right now. So and that means not overprescribing. So you never stop levodopa. So everybody didn't, no one said 1 or 4, so that's great. Never stop levodopa. The other thing that you don't stop is you don't stop your levothyroxine. Otherwise, this would actually kind of be fine to stop. Lots of people do stop their antihypertensives or they cut down on them, whereas you don't tend to stop your levothyroxine because hypothyroidism makes people miserable. So then it was between 2 and 5. Now, the thing about 2 is the warfarin is there for what reason? What is the warfarin preventing? Why do we give people with AF warfarin? Yes, so stroke. So that is a big thing. And so we don't want to stop them and stop them on warfarin and then immediately they have a stroke because that would cause a really, you know, bad event and it would make them pretty miserable in their last however many years or possibly kill them. So now this is a question mark because you could very easily argue, and this is what I love about polypharmacy is like it's a bit of an argument about it. You could easily argue he's having falls and maybe he's had some massive bleeds. Maybe he's, got these massive hematomas and things like that. If he's really suffering from his bleeding risk, then you do have to weigh it up and say, is the risk of stroke worse than the risk of bleeding? And so this is like this is where you really have to like put on your thinking hat. But in this case, compared to 5, this is the better option. But I think if this wasn't here, I probably would go with this one because the risk of stroke in a year is like 10% if you aren't anticoagulated. So it's high, but it's not like inevitable that he's going to have a stroke. And if he's really suffering from his warfarin, then you could argue that you could stop it. Or you can maybe change it to like a safer drug, like a DOAC, where those are much easier to reverse, or at least they come out of your system much easier and they're easier to take. So there are arguments to be had here. There are gray areas, but essentially, out of the 5, this is definitely the best answer because you're getting rid of your ACE inhibitors. You don't need that. Getting rid of the statin and the aspirin because those are both for secondary prevention, which we don't need now. And the solifenacin is an anticholinergic for his urinary incontinence. Now, again, you could argue if he's incontinent, then he's gonna fall over because he's rushing to the bathroom. But he could also anticholinergics have their own burden and they're pretty bad in their own right. Like they can cause falls and they can cause confusion. And older patients are definitely more susceptible to that. So I would get rid of that. And then, if he's struggling with the urinary incontinence, at least he has the option of like maybe he could have a catheter or maybe he could wear like the adult like diapers. Whereas, stroke, less options, less harmful options, So that's my thought process. So a little bit about polypharmacy. Just it's the use of multiple medications is technically 5 or more. But when you're thinking about it, consider the stop-start criteria, which is essentially like benefits versus risks, and other things to consider are things interacting with each other. Anticholinergics are not your friend, and as I said, like DOACs are a bit better than warfarin. Okay, so that's done. Please fill out feedback, and I think this is our last session because you guys only have 3 modules. So good luck for your exams. I hope you guys have a fabulous summer while me and Finola are suffering